The lecture today is about acute respiratory distress syndrome. First, the objectives: review the causes and differential for ARDS, briefly discuss the pathophysiology, discuss the clinical manifestations of ARDS, and understand the evidence-based treatment options. For definition, ARDS should have an acute onset, the chest X-ray of the patient should show bilateral infiltrates, and there should be no clinical evidence of left heart failure. This is a typical X-ray of a patient with ARDS. As you can see, there are bilateral infiltrates on this X-ray. First, the Berlin definition of acute respiratory distress syndrome. So this paper was published in JAMA in 2012. It was done by the European Society of Intensive Care Medicine with endorsement from the American Thoracic Society and the Society of Critical Care Medicine. It divided ARDS into three mutually exclusive severity categories: mild, moderate, and severe. And it took into account timing, chest imaging, the origin of edema, and the oxygenation. So for the timing, the ARDS development should be within 1 week of a known clinical insult or new or worsening respiratory symptom. The chest imaging should show bilateral opacities that would not be fully explained by effusion, lumbar lung collapse, or nodules. The origin of the edema, the respiratory failure should not fully be explained by cardiac failure or failure overload. And for the oxygenation, mild ARDS is a P to F ratio between 200 and 300, moderate between 100 and 200, and severe would be less than 100. All those values would be with a positive end expiratory pressure of more than 5. So what are the causes of ARDS? The most common one is pneumonia. Severe sepsis is another one. Aspiration, trauma, drowning, pancreatitis, fat embolism, smoke and chemical inhalations are other causes. What would be the differential? Left ventricular failure, pulmonary veno-occlusive disease, TRALI, or any interstitial or airway disease like hypersensitive pneumonia, acute eosinophilic pneumonia, acute interstitial pneumonitis. For the pathophysiology, it is caused by a direct or indirect injury to the alveolus, this injury causes alveolar macrophages to release pro-inflammatory cytokines. These cytokines attract neutrophils into the alveolus and interstitium, where they damage the alveolar capillary membrane. Whenever the ACM integrity is lost, interstitial and alveolus fills with proteinaceous fluid, and surfactant can no longer support the alveolus. Now for the pathophysiology. The consequences of lung injury include impaired gas exchange, decreased compliance, and increased pulmonary arterial pressure. Talking about the impaired gas exchange, the VQ mismatch basically is related to the filling of the alveoli and the shunting that causes hypoxemia. Also caused by increased dead space. So what happens is that it impairs carbon dioxide elimination and results in high minute ventilation. The reduced lung compliance is the hallmark of ARDS. It's the consequence of the stiffness of a poorly or non-aerated lung. So the lung that becomes fluid-filled becomes stiff or boggy, and to deliver a certain tidal volume, it requires a lot of more pressure than in a healthy lung. Increased pulmonary arterial pressure occurs in about 25 patients of ARDS patients. It results from hypoxic vasoconstriction and from positive airway pressure causing vascular compression. It can result in right ventricular failure. However, we do not usually measure pulmonary arterial pressure in ARDS patient in the ICU, unless there is another indication. Talking about the evidence-based management of ARDS, the first goal would be to treat the underlying issue. then to use low tidal volume ventilation, use PEEP to monitor the airway pressures, to use the conservative fluid management technique, and to reduce potential complications. We're going to talk about some papers that show the evidence base of all those interventions. This is one of the most famous paper in intensive care medicine. It was published in the year 2000 in the New England Journal of Medicine. This is the patient that was published by the Acute Respiratory Distress Syndrome Network about low tidal volumes that could be used in ARDS patients. The hypothesis of this paper is that in patients with acute lung injury, ventilation with smaller tidal volumes, basically 6 cc per kilo of ideal body weight, will result in better clinical outcome than traditional tidal volumes, which would be 12 cc per kilo of ideal body weight ventilation. Low tidal volume ventilation. So when compared to larger tidal volume, low tidal volumes of 6 cc per kilo of ideal body weight was associated with decreased mortality, increased number of ventilator-free days, and decreased extrapulmonary organ failure. Mortality is decreased in the low tidal volume group despite these patients having worse oxygenation, increased PCO2, and lower pH. The main hypothesis between low tidal volume ventilation is basically explained by the pathophysiology of how ARDS works. ARDS affects the lungs in a very heterogeneous fashion, so the normal alveoli are minimal in this lung, and these are the ones that actually participate in the gas exchange. Injured alveoli can potentially participate in this exchange, but they're susceptible to damage from opening and closing. And the damaged alveoli are filled with fluids and do not participate in any gas exchange. So the low tidal volume ventilation is a protective measure to avoid overdistension of the normal alveoli and to minimize the airway pressures. Now talking about about the use of PEEP in those ARDS patients. There was this study that was done and that was published in 2004 that showed that that compared patients with higher or lower levels of PEEP. So the hypothesis was that in patients with acute lung injury that were actually ventilated with 6 cc per kilo of ideal body weight of tidal volume, higher levels of PEEP would result in better clinical outcomes than lower levels of PEEP. Surprisingly, it was shown that a higher level of PEEP does not improve any outcome. It actually may negatively impact the patient. It can cause increased airway pressure, increased dead space, decreased venous return, and barotrauma. Obviously, every ARDS patient needs the PEEP, but the goal is to maximize alveolar recruitment and prevent cycles of recruitment-derecruitment. But the main goal is to avoid any injury to the lung. This paper called Ventilation Strategy Using Low Tidal Volumes, Recruitment Maneuvers and High Positive and Expiratory Pressure for Acute Lung Injury and ARDS was a paper that was published in JAMA in 2008. In this trial, 983 patients were randomized to two groups. One was the usual ArdsNet protocol ventilation system, and the other one was called the open lung group, where low tidal volume, higher PEEP, and intermittent recruitment maneuvers were used. And there was no statistically significant difference in mortality outcome between those two groups. This next paper also is very important because it helps us to determine how much PEEP is needed to actually use in a patient. So it was published also in 2008, and it was a multi-center randomized trial where 767 patients were actually recruited and divided into two groups. One received moderate PEEPs, between 5 and 9, and the other they had a level of PEEP to reach a plateau pressure of 28 to 30. The second group, didn't have a lower mortality, but they had better lung function and decreased day on the vent and less organ failure durations than the first group. So keeping the plateau pressure of less than 30 was a very good intervention that could be done. Talking about the airway pressure in the ARDS, the most predictive pressure of lung injury is the plateau pressure. The goal plateau pressure is less than 30, the lower the better. It basically reduces the risk of lung strain. It's important to adjust the tidal volume to assure a plateau pressure at goal. It may also be permissible to have plateau pressure of more than 30 in some cases, like obesity, pregnancy, and ascites. In case of high plateau pressures, it always represents some kind of pathology. It can be ARDS as we talk, pneumothorax, autopeep, a mucus plug, a right mainstem intubation, or compartment syndrome. Obesity can also cause high plateau pressures. This paper here talks about possibly putting a pulmonary artery or central venous catheter to guide treatment of acute lung injury. It showed that there was no need for routine pulmonary artery catheter use in acute lung injury patient, and it supported also the use of conservative strategy of fluid management in patients with acute lung injury. It showed that using the data from a PA catheter compared to that of central venous catheter did not alter survival, did not improve organ function, did not change outcomes for patients entering in shock compared to those without shock. Pulmonary artery catheter use resulted in more non-fatal complication, mostly arrhythmias. So it's important also in ARDS to actually use conservative fluid management. Um, Conservative fluid management improved lung function and shortened mechanical ventilation times and ICU days without increasing non-pulmonary organ failure. These conclusions were from this article that was published in the New England Journal of Medicine in 2006 called Comparison of Two Fluid Management Strategies in Acute Lung Injury. Why is that? It's because increased lung water is the underlying cause of many of the clinical abnormalities in ARDS. So after resolution of the shock, every effort should be done to actually attempt diuresis. In case you use CVP as a guide, the goal would be less than 4. Conservative fluid management shortens the time of the vent and the ICU length of stay. Talking about prone positioning, this article called Prone Positioning in Severe ARDS showed that early application of prone positioning in patients significantly decreased 20-day and 90 mortality in patients with severe ARDS. Now, how to wean from mechanical ventilation? Basically, whenever you think the patient is actually um, able to tolerate a spontaneous breathing trial, a spontaneous breathing trial should be done. How do you know if the patient is tolerating a breathing trial? If his SpO2 is more than 90%, if his spontaneous tidal volume is more than 40 cc per kilo per ideal body weight, if his respiratory rate is less than 35, if his pH is more than 7.3. There are also signs of respiratory distress that the patient should not show, like accessory muscle use, diaphoresis, marked dyspnea, or baseline tachycardia. If the patient tolerates the SBT, extubation can now be considered. Putting it all together, whenever you have a patient with ARDS, the first step would be to calculate the patient's predicted body weight. The formula differs a bit if it's a man or a woman. So you set the tidal volume at 6 cc times the predicted body weight in kilos, and set the initial rate to approximate the baseline minute ventilation. Then the FiO2 and the PEEP should be set to obtain a saturation goal of more than 88%. Whenever the shock has resolved, it's very important to diurese the patient to minimize lung injury. To troubleshoot the common problems that you can encounter, the main problem is a high plateau pressure. Whenever you have high plateau pressure in an ARDS patient, the first step would be to decrease tidal volume by 1 cc per kilo to as low as 4 cc per kilo of ideal body weight. It's important to ensure there's no pneumothorax, orthopeep, or any other reason for the actual change in compliance. In case the patients start to breast stack, um, one would be to increase the inspiratory flow rate, and the second one would be to actually give him more sedation or paralytics if needed. In case of hypotension, it's important to give some volume to the patient, ensure there's no pneumothorax, and at this point to minimize the sedation. In case of any acidosis, a pH less than 7.35, um, you can increase the minute ventilation. In case of refractory hypoxia, you need to ensure there's no mechanical trouble. Neuromuscular blockade can be initiated. Recruitment maneuvers, even though they don't improve outcomes, can help. Um, PEEP can be increased, and Flolan, which is inhaled ipraprostenol sodium, can be used. When inhaled, the vasodilator reaches the normal lung, and it's concentrated in normal lung segments and recruits blood flow to functional alveoli when it is oxygenated. It decreases shunting and hypoxemia and helps with hypoxia. In the past, the high frequency oscillation was often used in ARDS. Um, it is not anymore. The main reason is actually the study that was done in 2013, which was a multi-center randomized study. When in this trial, they randomized patients with ARDS into the first group, which received Ards protocol ventilation, and the second group, which actually received high frequency oscillation early in ARDS. They had to actually stop the trial because the mortality in patients that were assigned high frequency oscillation was so much higher than the one with the common protocol. So now high frequency oscillation ventilation is actually contraindicated. One of the last things we're going to talk about is the neuromuscular blockade in acute respiratory distress syndrome. So neuromuscular blocking agents may increase oxygenation and decrease ventilator-associated lung injury in severe ARDS. There was this multi-center double-blind trial with 340 patients. One group received 48 hours of Nibex infusion, and the other one was on placebo. It was found that early administration of the neuromuscular agent, blocking agent, improved 90-day survival and increased time off the ventilator without increase in muscle weakness. Um, the last thing we're going to talk about is basically supportive strategies. Uh, first goal would be to treat the underlying infection, DVT prophylaxis, head of bed more than 30 degrees, hand washing, um, proper sedation and analgesia, initiate early feeding protocol, avoid contrast nephropathy, avoid steroid use. All those therapies actually can help any ICU patient, but because the ARDS patients are even more fragile than the usual ICU patient, those therapies should really be enforced. As we said earlier, steroid use, there is no benefit of corticosteroid use on survival. As a conclusion, the recovery is very dependent on the health prior to the onset. Within 6 months, it will have reached max recovery. At 1 year post extubation, uh, more than one third would have normal spirometry values. ARDS can cause a significant burden of emotional and depressive symptoms in patients. They may even have PTSD after being survivors. Um, and that's about it.